I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's virtual events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's virtual events series.
Thank you all for joining us. My name is Rebecca Kiesling, and I am the program director at the Benjamin Rush Institute. Thank you so much for joining us for our first virtual event of the year. I see people who have been with us before and a bunch of new people as well. We started this virtual event series in response to the COVID pandemic when medical schools shut down. We've had a great response and a number of wonderful speakers. And so we're going to continue going even as our medical schools are opening up. There's still most of them, if not all, are doing virtual events themselves. But with such a great response, we're going to not only continue, but expand. We're looking into doing some debates on this as well, so stay tuned. This year, Benjamin Rush Institute is focused on expanding the education of medical students on free enterprise, free market healthcare alternatives that they are not getting in medical school. We're fearful that that might only get worse now. It's been an intense year already. Insurrection and rioting at the Capitol, censorship, an inauguration, and a new administration, bringing on our first female vice president. And in the midst of that, we're still in the middle of the biggest health crisis we have seen in 100 years. It was just a year ago that the US reported its first known case of a new virus that was circulating through China. This new administration takes over with COVID numbers at a high and hospitals full. And their immediate reaction is to sign executive orders reversing much of what the former administration did, talking about plans to bring back more government oversight, which is more big government. Even the American Medical Association, whose stated mission is to promote the art and science of medicine and the betterment of public health, is getting involved in pushing this new administration's agenda. In the latest journal of the American Medical Association, 4 articles covered policy, including the importance of censoring the public health message and healthcare as a right for all, making them clearly the arbiter of truth. We're going to get deep into what healthcare looks like today and tomorrow with an expert I feel so especially honored to speak with. I met her when she advised the Giuliani for President campaign on healthcare, and I was the coalition's director. She is the founder of the Benjamin Rush Institute and the chairwoman of our board of directors. Sally Pipes is the president, CEO, and Thomas W. Smith Fellow in Healthcare Policy at the Pacific Research Institute. Prior to becoming president of BRI, she was assistant director of the Fraser Institute, which is based in Vancouver. Ms. Pipes addresses and debates national and international audiences on healthcare. She writes a bi-weekly healthcare column for Forbes and one for the Washington Examiner's blog. She also writes a weekly healthcare column for Fox News. She was featured in Michael Moore's movie Sicko and has testified before numerous congressional committees and throughout the country. She participates in key radio shows nationwide, including the Larry Elder Show, Lars Larson, and Ed Morrissey's program Hot Air. Just recently, Encounter Books published her latest book, False Promise, False Promise, The Disastrous Reality of Medicare for All, which we're going to talk about today, which included a foreword written by the late Senator Tom Coburn. She has won numerous awards, including Human Events naming her one of the top 10 women in the conservative movement, a former Canadian, Ms. Pipes became an American citizen in 2006. I love reading what she says. I love listening to her. I am so honored that she is the chairwoman of our board, and I get to work with her all the time. I'm very excited for the day after this inauguration to get to introduce to all of you Sally Pipes.
Well, thank you, Rebecca, for that kind introduction. I'm delighted to be the chair and the founder of the Benjamin Rush Institute. This idea came to me back in the early 2000s when I became increasingly concerned when I would do debates and speeches at medical schools that there was no alternate vision for medical students other than the one that was pushing Medicare for all, single payer. And so I wanted medical students to see there is another side to the story. So 2008, we had our founding meeting, and of course, we're going strong, and I'm delighted to be still involved with Benjamin Rush Institute because it is one of my goals. I'm, totally, as Rebecca said, been engaged in the healthcare debate since 1988 when I was at the Fraser Institute, and we started our publication called Waiting Your Turn, A Guide to Hospital Waiting Lists. And now I'm going to talk about some of these things. I thought I would start off by talking about where I see things going forward from today. As you know, the inauguration was yesterday, January 20th, and President Biden and Vice President Kamala Harris were sworn into office. So it's an important year starting, today for healthcare. As you know, the Democrats' victory on the 2 Senate races in Georgia, Ossoff and Warnock defeated Perdue and Loeffler. And so now the Senate is 50-50, half is 50-50, and Democrats, Republicans. And of course, the tie vote would then, if there's a tie in a vote, that would then go to Kamala Harris, Vice President, to make a decision. So she will hold a lot of the power in this healthcare debate. And as many of you probably know, she is a very progressive liberal. She is a big supporter of Medicare for all. I do think with the razor-thin majority, both in the House and this very tight 50-50 split in the Senate, it's going to be very difficult for Congress to pass single-payer legislation or President Biden's goal, which he has talked about often, of setting up, including a public option, which would be a government insurance plan to compete against private insurers in the exchanges. He, of course, just following his election, he changed the name of Obamacare to BidenCare. And as he said, he doesn't support single payer, but BidenCare, building on the Affordable Care Act and the public option, these are basically stepping stone approaches to single payer. So I think that these are important things to note. There is, however, plenty of things that the Democrats can do to transform Obamacare into BidenCare, but they're going to command very large amounts of government funding, which of course is funding by Americans. Some of the things that are on the agenda, as I say, the stepping stone approach to single payer, more generous subsidies for exchange coverage, the premium tax credits for those earning between 100 and 400% of the federal poverty level. A family of 4, that would be an income of $106,000. He's going to tie the subsidies to the gold plans rather than the silver plans, which have been the law under the Affordable Care Act. He also has said that no one would pay more than 8.5% of their income for premiums. So, as I say, they would tie the premiums to the gold plan, and of course, the premiums under Obamacare on the exchanges. Remember, President Obama said he wanted to reduce the uninsured rate to 0, and he wanted to reduce the cost of healthcare. Well, under Obamacare, the premiums went in 2014 from $264 a month for exchange coverage to $523 per month. As a result, many people who became through time ineligible for the subsidies because their income went up above the 400% of the federal poverty level. Many of them left the market. In fact, 2.5 million out of the 10 million people who had exchange coverage left because they were no longer getting the subsidies. So President Biden wants to wants legislation so that anyone who has employer-sponsored coverage could drop out of their ESI and enroll in the public option. But as I say, I think it's going to be very difficult to accomplish this with the makeup of the Congress. Under Obamacare, the regulations included 10 mandated essential benefits. And this, of course, has led to the extreme cost increase of coverage and people exiting the exchanges. I think President Biden wants to expand Medicaid. All but 12 states expanded Medicaid under the Affordable Care Act. I think what he is going to try to do is say that those 12 states would get 100% federal funding if they expanded their Medicaid programs. This is going to be extremely expensive. The feds are already paying $389 billion a year for Medicaid coverage. Medicaid enrollees who are in those 12 states that did not expand their Medicaid programs, under his plan, he would let them sign up for the public option coverage, and they wouldn't have to pay any premium or any deductible. So I think those are very key issues. Another key issue of his is he promised during his campaign that he would support reducing the eligibility age for Medicare from 65 down to 60. The Congressional Budget Office has said that this would cost about $100 billion a year, and it would add 23 million people to the rolls of Medicare, which there are about 60 million people on Medicare today. The CBO has also said that Medicare Part A, the hospital part, will now be bankrupt by 2024. A lot of this has to do, of course, with the increasing number of people joining Medicare and the fact of the pandemic, which Rebecca had mentioned. Looking at the public option, which, as I say, I think will be very difficult to get adopted, I think it is something that he is really going to be pushing. The public option was in the House version of the Affordable Care Act. The Senate stripped it out because they didn't think that it could pass, but it's back. And I think there's no question, as I said earlier, that it is a stepping stone approach to single payer or Medicare for all. So the public option would have a competitive advantage over private insurers because it would allow the providers and hospitals to reimburse at rates similar to those paid by Medicare. Private hospitals, though, right now, they pay 247% more on average to cover the loss of funds from the government plan under the government's Medicare. Doctors under Medicare are paid 35% less. So the cost advantage of the public option would be to underprice private insurers and move customers off of private coverage and onto the public option. As more and more people, of course, patients leave their private plans, hospitals and doctors would see a decline in revenue. They would have to raise their rates for private insurers. And ultimately, private insurers would be crowded out of the market. They wouldn't be able to stay afloat, and we would all be left in the public option being the only option, and that would open up the case for single payer. President Biden has said the cost of his plan, $750 billion over 10 years. And we all know that most government programs never end up costing what the prediction is. Most government programs end up costing a lot more. Look at Medicare. It cost $3 billion in the first year. It was projected to cost $12 billion by 1990. In fact, it cost $110 billion. So as I say, no government program ever costs what the government economists predict that it will cost. During the debates for the Democratic nomination for president, as I said, candidate Biden said he did not support Bernie Sanders' single payer plan. But as I say, his plan is just a stepping stone approach. Senator Sanders has been an advocate for many, many years for single payer, and it really came to the fore when he was running in 2016 against Hillary Clinton for the nomination, which he did not get. But he introduced single payer bills into the Senate in 2017 and 2019. And of course, Kamala Harris, our new vice president, she supported and signed on to both of Senator Sanders' single payer bills. So she is very much in favor of this. We keep hearing from Senator Sanders, House member Alexandria Ocasio-Cortez, that they think that they really are pushing now for single payer healthcare, and particularly they see it as a shoe-in because of the pandemic. So interestingly, Senator Sanders will be the new chair of the Senate Budget Committee. He has said publicly that he would like to end the Senate filibuster, and so that there has to be 60% votes to pass something. And he also has said that he wants to use budget reconciliation, which would only need a single majority for getting single payer health care. I personally was upset that President Trump was not able to repeal the Affordable Care Act when the Republicans had control of the House and the Senate up until 2018. But President Trump did sign some very good executive orders because we want competition and choice in healthcare. We do not want a takeover of the healthcare system by the federal government. Some of these executive orders that I really like were expanding and allowing the use of short-term limited duration plans, association health plans, so that people that are in groups like think tanks could get together and have a larger group and therefore get better rates for their coverage. He also signed an executive order allowing price transparency so people can know when they're having to go to the hospital what something will cost. And I think telehealth, which I've been promoting for many, many years, finally, came into its own because of the pandemic. But it is worrying. I really believe that President like Biden and his administration, when you look at who is in it now in the healthcare space, he's going to try and have several of these executive orders reversed. Particularly interesting is the fact that the nominee for Secretary of Health and Human Services, Xavier Becerra, the Attorney General of California, he actually took over that role when Kamala Harris became the California senator in 2017. Mr. Becerra was in the House for 24 years, a big supporter of single payer healthcare. As Attorney General of California, he was very much also in favor of single payer healthcare for the state of California. It didn't go through, it never moved beyond the Senate. But he, of course, has been very vocal about his support of getting rid of association health plans, short-term limited duration plans. And of course, he is the head of the Supreme Court case, which oral arguments were heard on November 10th. That is Becerra and 18 other attorneys general against the state of Texas in trying to say he believes that the Obamacare, even though the individual mandate was eliminated because of the Jobs Act in December 2017, he believes that the law is still constitutional. So we were going to see what happens. We'll probably see a decision in that court case in the spring. So the people on the street seem to think that the court will rule that, yes, the individual mandate has been eliminated, but the law is still constitutional. So we'll have to see what happens there. But I know this is Mr. Becerra's big case, and he's been pushing it, and he really wants to see Obamacare survive and support the President Biden in the expansion of Obamacare. As I say, Senator Sanders and AOC are pushing hard for single payer. He says that the pandemic shows how healthcare should be a human right, and we can talk about that later, and that Medicare for all is needed more than ever. There are some exciting deregulation efforts, but as I say, many of them could be overturned. The latest Gallup poll shows that 55% of Americans support the idea of single-payer healthcare, but many don't understand what single-payer means. Single-payer means that there would be no private coverage allowed for anything considered medically necessary. All private coverage would be eliminated. The only things where there would be private coverage would be for, say, LASIK surgery or cosmetic surgery. But as I say, many people don't understand what that would mean. If you have 55% of people supporting it, but when people polled were asked, well, what about if you had to pay higher taxes for the government fully running the healthcare system? Support dropped to 26%. And when people were asked, well, how do you feel if you would lose your employer-sponsored coverage, which 160 million Americans have, support went down to 37%. So there's a huge educational effort that needs to be done to explain to the American people what it would mean for their health care when the government takes it over. And it wouldn't be cheap, as Charles Blehaus at Mercatus has said. It would cost between 30 to 40 trillion dollars over 10 years. And it wouldn't, even if you doubled all personal and corporate income taxes, it wouldn't be enough to cover it. So it would mean that doctors would see their reimbursement rates cut down to Medicare, what they get reimbursed for Medicare. So their salaries would go down probably 35 to 40%. We would all face increased taxes, a 7.5% new payroll tax, a 4% income tax on people earning over $29,000 a year. We would see wealth taxes. We would see new taxes on large financial institutions. So it would be a very expensive undertaking, but the worst thing is that it would result in doctor shortages, long waits for care, ration care, and as I say, higher taxes. So in America today, the average primary care doctor earns $313,000 a year. Canada, the country where I'm from, which has a complete government-run healthcare system for anything considered medically necessary, doctors there earn on average $146,000, and in the UK, under the National Health Service, about $134,000. So a lot less when government is determining how you will get paid and how much you will be paid. And as Amy Finkelstein at MIT says, these numbers, 30 to 40 trillion over 10 years, are probably low because people, when they think something is free, they're going to demand a lot more of it. So if you look at Canada, as I say, where I'm from, and the Fraser Institute, where they publish the waiting list survey every year, the average Canadian last year waited 22.6 weeks. That's over 5 months from seeing a primary care doctor to getting treatment by a specialist. That is the only way the government can control the fact that the cost, the government is spending 11% of gross domestic product on healthcare compared to 18% here. So at 22.6 weeks, this is the longest waiting time in the history of keeping waiting lists, which started in 1993 when the average wait was just over two months. And it's not free. Bernie Sanders often says in the media, in his TV interviews, well, Canadians, their healthcare is free, and we're paying $11,000 a year on average for healthcare coverage. Well, the average Canadian pays for their healthcare in hidden taxes. Last year, the average Canadian family paid $14,474 in hidden taxes. So it's not free, and then yet you still have these long waits. Care is rationed. The older you are, the less likely you are going to have access to timely care. My own mother died in Vancouver, Canada, from colon cancer because when she thought she had colon cancer and went to the doctor, she was told she could not get a colonoscopy because there were too many younger people under 65 on the waiting list waiting for a colonoscopy. She finally got a colonoscopy when she was hemorrhaging, and she went to the hospital. She died 2 weeks later from metastasized colon cancer. This is what happens when the government has to ration care. So as Madam Chief Justice Beverly McLaughlin, the just retired Supreme Court Justice, said, access to a waiting list is not access to health care. Having a care card does not mean that you can get care. So as I say, long waiting lists, my mother's example, Michael Bublé, the crooner, his son in Vancouver at age 3 was diagnosed with liver cancer. They didn't stick around in Vancouver waiting for to get care in Vancouver. They went to Los Angeles to the Children's Hospital, and they got immediate care. And now he is 6 years old, and he is has no signs of liver cancer. So people have Canadians have alternatives. They can come to the U.S. In Britain, under the National Health Service, under this COVID, there are 4.46 million Brits waiting for hospital treatment, the highest number since they started their records. So cancer operations, both in the United States, the UK, and Canada, the cancer diagnoses are way down because people are not going to their doctors to get diagnoses if they think they have a tumor or they think they have some form of cancer. And we've seen that the Lancet journal has predicted that delays are going to lead to an increase in cancer deaths within 5 years of diagnosis. So as former Chancellor of the Exchequer in the UK said on the National Health Service, the NHS is the nearest thing to a religion that we have, and it can't be criticized. And if we have a government takeover of our healthcare system, the same thing will happen. The Guardian newspaper said, the National Health Service is the world's best healthcare system. Its only black mark is its poor record of keeping people alive. And I know many of you are too young to remember, but Mick Jagger, the frontman for the Rolling Stones, he, of course, had to have emergency heart valve replacement surgery a couple of years ago, and he is a Brit. But as his younger brother said, he didn't go to England and sit on the National Health Service waiting list. He had his heart valve replacement done at New York Presbyterian Hospital. It was very successful, done immediately, and he was back on the stage very, very quickly. So I think it's important that you understand that healthcare is not a human right. It's a good and service. We can talk about that later. And that if the government were to take over our healthcare system, we would have ration care, long waiting lists, doctor shortages, and of course, higher taxes. The American Association of Medical Colleges has predicted that by 2030, there will be a shortage of 139,000 doctors in this country. Many docs are retiring early because of all of the paperwork and demands and mandates and regulations under Obamacare. It would be even worse under single payer. So I'm hoping that I will get some interesting questions from all of you, and that we hope that competition and choice will prevail in our healthcare system. Because as PJ O'Rourke, the humorist, said, if you think healthcare is expensive now, just wait until it's free. So thank you, and I look forward to some questions.
We do have some great questions. They're coming in from all over. I have some great texts from some of our student leaders. We have a number of different, so just to let you know, and I think I forgot to say this earlier, we have supporters, we have students, we have some physicians on. So it's a great smattering of people that we have on board here. So I want to start with one. Do you not agree that we have socialized medicine already in one sector of our medical system, the VA?
Well, yes, when people in Canada say, oh, the United States is so terrible, people are dying in the streets, the private sector, it runs the healthcare system. 50% of healthcare in the US is already in the hands of government through Medicare, the seniors program, Medicaid, the program for our low-income people and disabled people, the Veterans Administration, and of course the CHIP program. And the VA, I remember I was debating Uwe Reinhardt from Princeton a couple of years ago. Unfortunately, he passed away a couple of years ago, but this was before he passed away. And he interrupted my presentation and said, Sally, we have an example of single payer healthcare in this country, and it is so successful. I said, Uwe, what is that? And he said, the Veterans Administration. Now, as we know, there's been so many articles in the press. Under the Trump administration, they were trying to, privatize parts of the VA because veterans were facing long waiting lists for care, ration care. In many cases, people were dying on waiting lists. They couldn't see a doctor. So the VA had all the examples that a Canadian or a British healthcare system had, not giving our vets who served our country so well access to timely care. And I think one of the great things that telehealth is a very good thing because it's going to help our vets. But it is a single payer system, and it has been a disaster, as we've heard in stories in the media from doctors and from vets, and politicians really, were being challenged on it. So this is an example of why we don't want a government takeover of our healthcare system like the VA.
there's been a lot of publicity about the number of medical students, medical school applications this year because of COVID. But somebody said, I suspect this means the best minds may choose not to go into medicine when they hear about this, because doctors become slaves under a government system. And I think you spoke to this a little bit when you talked about early retirement and things like that.
Right. Well, so in Canada, doctors are actually private employees. They work for themselves, or they could work for a hospital. But the problem is that they're paid. Their remuneration comes from their provincial government. So the provincial government sets what doctors are going to be paid. So they can't bill a private insurer. And my cousin, who's a surgeon in Vancouver, said, it's amazing to me that so many people in America think that, the government system is easy. He said, you have no idea how long I have to wait to get paid by the BC government for the procedures that I do. And I may be the best or the worst ophthalmology surgeon, but I get paid the same as the best or the worst. There's no there's no difference in terms of how good you are at your profession. So I think we are going to see, as I say, the American Association of Medical Colleges has said that there will be a shortage of 139,000 docs by 2030. Many are getting out. I mean, the whole electronic records and things under Obamacare caused a lot of doctors in their mid-50s to say, I'm just not going to put up with this anymore. I'm going to retire early. Another thing is that a lot of I do believe that the best and brightest, if we get single payer, will not go into medicine, because they're going to be like government employees, and it would be very difficult if you've been trained as a specialist, not being able to practice the kind of medicine that you've seen. One of the things that has been interesting during COVID, as you say, a lot of the medical schools, have been closed. Everything is telehealth and Zoom, as this is. But some of the medical schools have reduced the 4-year medical school being in medical school from 4 years down to 3. And it's going to be interesting to see if that becomes a factor, because if so, a number of students, the program would be shorter, and they'll can become a doctor earlier, and will maybe help advance the number of doctors that we have, and might help to reduce that shortage. But Harvard tried that during the COVID. A number of medical schools, Duke, Ohio State, and UNC reduced the number of years from 4 years down to 3. So I think expanding programs like this and allowing more students to go to medical school is a good idea. The problem is that if we're going to have the government take over, as we said earlier, it's going to mean that the best and brightest kids are going to become lawyers and MBAs and not go into medical school. And traditionally, the best and brightest kids go into medicine, and they also, want to be doctors. They want to help.
Yeah, and I think you're right. I tell people one of the reasons I do what I do is because I don't want to see that burnout rate continue. I want to make sure that doctors stay in the field and continue to practice medicine, because they know there's different ways to practice medicine. You spoke about MBAs. One of our student leaders, who is now, she's a medical student, but taking some time to get her MBA. She has a question. I have to scroll back up. Her name is Shelby. She says, thank you for the talk. I was wondering what you think the future of DPC would be like if the US inches closer to single payer. I personally want to start a DPC, and the current political climate we live in is concerning.
Right. Well, I think that will be very, very difficult, because every doctor will be an employee of the federal government, or if they did go the Canadian route, and every doctor would be an employee of their state government. So DPC is a great idea. It's being tried, in Oklahoma and Florida. It's a terrific idea. It reduces costs. It allows more people to get, to afford coverage. So I'm very, very big on DPC, but I'm very worried that, either under Biden, if we get the public option or we get single payer, this will all be out the window. Everybody will be patients of the federal government or of their state government.
What areas in our health system do you think are the most wasteful? How do you think that should be measured, and what are the sources that you use?
there's where you see a lot of the inefficiency, the fraud that is being, is being written up in the media, and waste is in the government programs, whether it's in Medicaid and Medicare have had huge examples of fraud. So, they don't, because the government doesn't have to, make a profit. If a government program loses money, which would happen under Obamacare or SinglePayer, the Treasury will just step in and provide cover the loss, and we will have to face higher taxes. So most of the fraud, the inefficiency, and the waste in healthcare has been in these government programs like Medicare and Medicaid, and you see it many times in the media how much that is. The private sector, sure, there are going to be some people who are fraudulent, but for the most part, the private sector is the way to go. Just like in business, we've seen, with these unemployment benefits under the pandemic, how much fraud, particularly in California. The EDD paid out a lot of money to people who've been dead for several years. So the private sector has checks and balances. The government doesn't have as many, and I think that's where most of that fraud, inefficiency, and waste will be, and particularly under a government program.
This is from a current physician. I'm a private physician in solo practice for 27 years. Thank you for joining us, sir. I cannot see a single payer in our society. I'm frustrated to be a physician because I'm lumped in with healthcare provider. And I'm sorry if I don't see what your word started to group doctors in a category called healthcare providers. Do you agree that people don't understand that this lowers the status, is someone that draws blood versus physician, and what that looks like?
Yeah, I think I understand the question. One of the things that is interesting is, as Obamacare came into being, which was signed into law on March 23rd, 2010, the first exchanges became operational on January 1st, 2014. As I said, the premiums have been, were very high. The deductibles are high. Many people can't afford to use them. But one of the things that's interesting is that under Obamacare, a lot of docs in single practice docs had their own practices have gone into hospital groups. We've seen a tremendous decline in the number of doctors in solo practice and the movement into working for hospitals. Apparently 49% of graduating specialists are now joining joining hospital practices. A lot of this has to do with the fact that many young docs don't want to, work, 24/7. They want to have, of course, spend time with their family. They have medical debt from medical school, and they want to get a certain salary. They would earn less. But many docs, like my OBGYN, who was in solo practice, he went and joined the Sutter Medical Group because he said the young people didn't want to deal with all the paperwork and things in solo practice. And he said it was, after a couple of years of being part of the Sutter Group, he retired early. He said there's so much paperwork, there's so many rules and regulations, there are controls on what you can be paid for different procedures. And so, he retired early, as have many. But I think this is a very frightening trend as more and more doctors join hospital practices, and then of course are grouped in with, whether it's nurse practitioners, physician's assistants, all of these things. So it's a terrible thing that we've seen as the government's got more involved, as I say, in our healthcare system through the Affordable Care Act. That, of course, we've seen this move to docs working for hospitals and being lumped in with PAs and NPs, and there's no question nurse practitioners and physician's assistants can do certain things. They don't have to be done. They don't have to be done by doctors. But they're not physicians. They haven't been to medical school. They may have done a degree in medical services, medical technology. But it's a very worrying thing, I think, about this move. And it's sort of, as you mentioned earlier, Rebecca, about the American Medical Association. American Medical Association only represents about 18% of doctors in this country, but the man on the street thinks every doc belongs to the AMA. And the AMA in the last few years has been moving closer to votes on single payer and away from, private private practice. So I think it's worrying. A lot of the docs that don't support single payer are joining specialist groups like the Association of Pediatricians or orthopedic surgeons or whatever, because they are, upset with the way the AMA is trying to control everything. And as you said earlier, their latest salvo is to be making more decisions on behalf of doctors.
Thank you. Yes, we spoke briefly about AMA before we got started here. I told you as I was on my soapbox, I have a distinct problem with the American Medical Association pushing policy so strong and pushing an administration's policy through their 18%, because they do also have a very strong force in what medical schools are doing in their agendas, in what they're teaching. Last year, they came out with that they want to start economics in medical schools, and I'm all for that because I think that's great. Except we know what those economics classes are going to look like. It's not going to be well-rounded. They talked even earlier last year about putting climate change issues into medical schools. Those things aren't, they talk about being evidence-based and they're not.
I was just going to say, we should have a brief conversation about healthcare is being a right, because this is what, Bernie Sanders, AOC, Pramila Jayapal, the squad, all are saying healthcare is right. And I think, I've done a lot of writing on the fact that healthcare is not a right. It's not a right for everyone, and it's not a privilege for the few. It's a good and services. And like all goods and services, healthcare is necessarily scarce. But declaring a right to healthcare that is green lighting essentially unlimited demand for healthcare will not miraculously engender unlimited supply of doctors. And that's why you will get long waiting lists and ration care. I mean, it's unclear how large would that right be? We have a right to life, liberty, and the pursuit of happiness. But would a healthcare right mean a right to the very best care, or would it be a right to equal care, which is the way it is in Canada? If it were a right to equal care, would the government have the right to ban people from paying for better care? As in Canada, you can't pay for better care unless you come to the US. And we've certainly seen under the COVID, a number of people from the east coast of Canada are flying to Florida to get in line to get a vaccine because the wait is even longer in Canada. But does the right to healthcare come with any corresponding duties? If I have a right to healthcare, does the government have the right to tell me how to keep myself healthy? Do I waive that right if I'm a smoker or if I'm obese? These aren't hypotheticals. In the UK, under the National Health Service, patients are only eligible for certain procedures if they quit smoking and are no longer obese. So healthcare is a good and a service like anything else. And so we want to make access to healthcare. We promote that. We want affordable healthcare, but choice and competition will lead to affordable, accessible, quality care. A takeover by the government, either immediately under Sanders Medicare for All or a Biden's public option, is not going to provide what the American people really want.
I'm thrilled you got into the right of healthcare. I think that is fundamentally, it's such a big part of what I think the Biden administration is going to focus on. We know Bernie Sanders did. I think that right of healthcare is just a fundamental issue. And I know our students have a hard time at times talking about how to counter that argument, because so many of their peers are coming up with everybody deserves it. That's a big thing. Achieving, one of our students, or one of our newer students, just, she put achieving health equity because access to healthcare is deemed a right is often an argument for single payer system, one that is forced into many medical school curricula. And she's right. It's all over the place.
What I should do, Rebecca, after this, I'll send you my chapter from the Claremont Review of Books on Is Healthcare a Right? Because it's a much longer conversation about than just what I just did now. But your students, you might want to put it on your website, and your students could read it and come up with talking points for arguing against.
That would be great.
What this would mean.
Somebody asked, how do you define a human right?
Right. Well, how large is that right? And what we have if you had a right to healthcare, well, wouldn't it be more important to have a right to food? Because if we don't have food, we can't eat. Should we have a right to housing? These are some of the things that the progressives are really pushing on the American public. Everything will have right, but everything will be dumbed down to mediocrity. And we do have the very best healthcare in the world. People come from all over the world to get to access to the latest treatments, the procedures, the innovation in the pharmaceutical and the biologic sector. I mean, it's amazing. I mean, we in this country, Pfizer, BioNTech, and Moderna developed the vaccine for COVID in 9 months, and it finally got emergency use authorization. This doesn't happen in a country like Canada, where the government fully runs the healthcare system. There is no innovation because they have price controls. So we want to continue to have America. We're a wealthy country. We've been a wealthy country, and we want to have access to the very best. And government takeover is going to bring everyone down to dumb down the system so that we're all mediocre and none of us will be able to access the best treatments and procedures. And where will we go? I mean, as I say, 300,000 Canadians out of a population of 37 million cross the border every year and come into the US and pay out of pocket for MRIs, CT scans, heart valve replacements, things like that. Where will we go if the government takes over our system fully?
Yes. So we have a woman on who calls herself, and I love this, and she calls herself a 67-year-old ordinary person. I'm very thankful that you're on, ma'am, because you're going to help us spread this message as well. So I appreciate you joining us today. First of all, you said earlier, the same person, you said that government still dictates what they can get paid for. We're talking about in this conversation, which she mentioned before, she mentions the government dictating what doctors can get paid for. And often they can't use their best judgment. Now, when you say that, when she says that, we're talking about the doctor-patient relationship there. And that's at BRI, that's in our mission, is furthering the doctor-patient relationship. We've always stood for that. Thank you. And can you talk to that and what healthcare and where we are and where we could go, and what could that, in your opinion, do to the doctor-patient relationship?
Well, I mean, as if we go to single payer or the stepping stone approach, the doctor-patient relationship will be totally reduced because, first of all, doctors will be employees of the government. They will be paid, as I said earlier, a reimbursement rate, but is paid for whatever the procedure is, not whether you're the best or the worst. So it's going to bring down that level of mediocrity. It's in Canada, so many, as I say, there's a huge shortage of doctors because the reimbursement rates are so low. As I said, Medicare reimburses doctors at about 35%, Medicaid at about 40% of what they get paid for treating private patients. So those people who have private insurance have to end up subsidizing the doctors who are, who to cover the losses on Medicare and Medicaid. I know my own OBGYN said he loses significant funding on his Medi-Cal patients. That's the California Medicare system. He barely breaks even on Medicare. So it's people that have private coverage like myself that we have to pay more in order to subsidize. 1 in 3 new Medicare eligibles is already having a hard time finding a doctor because doctors are not taking these patients because of the low reimbursement rates. When you look at Medicare, look at the number of people on Medicare who sign up for Medicare Advantage because if they can't find a doctor, the Medicare rates are so low. Medicare Advantage pays higher, or they have Medicare supplemental plans. about 30% of people are on Medicare Advantage now, because Medicare, after we pay all these taxes every year for Medicare, it's not providing the coverage, the reimbursement rates for the doctors. And I think Bernie Sanders never talks about the fact that these reimbursement rates are so low, and therefore doctors aren't taking these patients.
Yeah. Going back to the right again, one of my favorite people in this movement and another extremely bright mind, Dr. Marian Mass, who we were privileged enough to have had on before, says calling it a right is also a way of starting an argument, calling it a need, and then you get a continuum of what individuals actually need. Calling it a need also avoids the fight. That's true. Good point there. I want to talk about this other question. We still have a little bit of time. The general public has been taught that healthcare should be free. How can we help them understand that they would get, if you had a few brief talking points for us, how they would get better quality, less expensive healthcare in a free market?
Well, we need to, competition and choice is the answer. We've seen, under the short-term limited duration plans, which are much cheaper than exchange plans, because the 10 essential health benefits covered under Obamacare are not there. And so insurers can provide cheaper coverage. And this is really good coverage for people who've lost their job. They're not on COBRA. And so they're looking for, a job, but they're in transition. And it's particularly good for young people who probably, aren't going to have many medical issues, but they want to have healthcare in terms of having coverage for a catastrophe. We need to expand health savings accounts. Health savings accounts, now there are over 20 million Americans have HSAs. You put that money into your HSA account every month. It is tax-free. You can use it for things that aren't covered by your insurance. We need to expand health savings accounts. We need to, part of the Trump executive orders were the health reimbursement accounts, allowing people to use their HRAs to get the premium money from their employer. They can go out and use their HRA to buy their own coverage. If they lose their job, then they don't lose their coverage. So there's so many things. And also, one of the terrible parts of our healthcare system in this country is the fact that during World War II, when wage and price controls were in, the government gave employers the right to write off the cost of healthcare. And so, 160 million Americans get their healthcare through their government. I think one thing I would like to see is that individuals should be able to get their healthcare tax-free in the same way that those people who have employer coverage do. But the idea was a terrible idea in the first place, and I'd love to get rid of that. But under the current makeup of Congress and the administration, this is not going to happen. That is a long-term goal. We need to. Medicare should be there, definitely, for people who are older and need that coverage. But there are a lot of people on Medicare that could afford their own coverage, and it would take the pressure off the Medicare program. And people like the Warren Buffetts of the world, they shouldn't be even eligible for Medicare. Even though they paid into it, I think Medicare should be there for those seniors who do not have the money, can't afford to buy their own coverage. But let's increase the age of eligibility, give people options. There are so many things that can be done, but putting everyone in a government-run program is going to increase the cost of healthcare. And as I said, in Canada, when Bernie Sanders gets up on the stump and says healthcare in Canada is free, remember the hidden taxes that the average Canadian family pays: $14,474 a year for care where you have to sit on a line. Care is rationed, and particularly for the elder. There's a movement in this country going towards ICER, which would determine your age and what your contribution to society is, and are you then worthy of having this treatment. This is the system in England called NICE, where the government actuarial team determines the value of your life, the cost of the treatment, and then if the value of your life is if the value of the treatment is more than your life, then you're not able to get that. So this is something else that is very worrying, and I think under the new administration, there's going to be a push to, determining who is eligible as you're older to getting the best treatments and the best care.
Our last question, trying to be cognizant of your time, this is a great question. We have talked a lot about the portions of our current system that are broken. What works and what can be reformed, in looking at some of the positives. So what is working and that can be reformed instead of just stopping?
Well, I would say one thing is, short-term limited duration plans, letting them go, let people that want those plans get those plans. Attorney General Becerra, who will be perhaps is nominated to be Secretary of HHS, he wants to get rid of short-term limited duration plans. Everyone should be able to get the type of coverage that suits their needs and those of their families. Association health plans where, groups of individuals can band together according to their area of expertise and get coverage, and it would be cheaper because the group would be larger, therefore more affordable care. We need to, as I say, increase the age of eligibility for Medicare, because when it came into being in 1965, the average person lived to age 69. Today, the average American lives to 79. But Joe Biden wants to reduce the age of eligibility for Medicare from 65 down to 60, which will result in, as I said, a lot of the care is hard to come by. A lot of Medicare people already cannot find doctors. So that's something important. We need to expand retail clinics. A lot of retail clinics, I'm surprised that retail clinics haven't been a place for people to get vaccinated. CVS, Walgreens, retail clinics, these are all places that have great systems of distribution and should be able to be used. So expand retail clinics, price transparency in hospital. That's one of the last executive orders that Mr. Trump signed into law. People need to know what a procedure is going to cost. You can shop around, not when you're having a heart attack, but for the most part, people should be able to know what that cost is. So price transparency, expanding telehealth. Not everybody needs to go to the doctor, and telehealth allows people to get access to specialists who they might not be able to if they live in a rural area. So those are some of the things, but competition and choice will lead to America continuing to have the very best healthcare, and letting the government take it over will reduce that option and lead to shortages of doctors, the best and brightest not going into medicine, ration care, long waiting lists, and we have to pay a lot more. As I mentioned, in Canada and the UK, it is not free.
This was a great discussion. I am so thankful for you and everything that you do for us at BRI, at PRI, getting the word out as you do, and your expertise, because we need to continue now more than ever. We need to continue this education because it's so important. What we do at BRI and getting the word out as early as possible to our future. The future of medicine is so important. So I'm very thankful for your time today. We still have questions coming in. I just put contact information up so we can continue this discussion. I put both of our Twitter accounts up. So they're there. Our Facebook page is there as well, and my email address. So we can continue this discussion. If people continue to have questions, please let me know. And we will monitor all of that, and we will get Sally Pipes involved in that discussion as well. This video will be up on our YouTube channel in just a couple of days. If you'd like to go back and view it immediately, it will be on our Facebook page, and we will link to it as well. You can always send me an email, and I can send you the link when it gets up. Go to benjaminrushinstitute.org and sign up for our newsletter, because that's the best way to get updated on more virtual events. And if you are a student that I don't know, please make sure you email me so that we can talk about getting a chapter started at your school. We are growing rapidly, which is fantastic. The more the merrier, because we need to get that information out. Sally, thank you for everything you do. Everyone, thank you for joining us today, and there's more to come.
Thank you, Rebecca. And it's an educational issue that is so very important. And BRI is a terrific organization. And as I say, I'm chairman and I founded it, and I just want it to survive and grow because it's so important. So thank you. And thank you all for participating today.
I hope you enjoyed today's edition of the Benjamin Rush Institute's virtual events series. To learn more about our educational programs and events just like the virtual events series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's virtual events series.